Hello, and welcome to the Lead Center webinar on value, outcome, and performance-based payment methodologies to advance competitive integrated employment. This is the last of three webinars on this topic. The first one was focused on state Medicaid long-term supports and services and managed care long-term supports and services systems. The second one focused on providers and gave the provider perspective, where we heard from providers who were using these value-based payment methodologies in their services. And this one focuses on state vocational rehabilitation and behavioral health systems. The recordings for the first two webinars are posted and the links are in the chat box. This one will be posted as well in about a week. We'll talk about that at the end. Before we get started, I wanted to go over a few housekeeping details. This webinar is being captioned. If you wish to personalize the captions, click the live transcript button on the Zoom panel to find the Hide Captions button and adjust caption size under the subtitle settings option. Alternatively, you may open a captioning web page in a new browser. Click the link posted in the chat box, and it appears here on the side. Adjust the background color and text color and font using the drop-down menus at the top of the browser. Position the window to sit on top of the embedded captioning. We encourage you to ask questions during the webinar. If you have content questions, please click on the Q&A button at the bottom and type in your questions. If you have other questions about captioning or you need tech support, type your question into the chat box. I am Rebecca Salon. I am Senior Advisor for the Lead Center. We are Office of Disability Employment Policy funded policy development center focusing on the Workforce Innovation and Opportunity Act. And I'm very happy to be with you today. We're excited that so many of you were able to join. This is just going to be a wonderful webinar. Today's presentation highlights a brand new publication from the Office of Disability Employment Policy. And it has a lot of the examples that will be talked about today. It's something that you have a link to in the chat box. It will be posted on the website tomorrow so that it'll be available to everyone. We'd like to start by offering you some words of welcome from Rose Warner, who is Senior Policy Advisor with the Workforce Systems Policy Team at the Office of Disability Employment Policy at the U.S. Department of Labor. Rose?
Thanks, Rebecca. Good afternoon, everyone. As Rebecca said, my name is Rose Warner, and as she also said, I'm a Senior Policy Advisor at ODEP. For those of you returning to this webinar series, welcome back. It's really good to see you again. For those of you here for the first time, welcome. You are in for a real treat, all about rate restructuring, specifically in the vocational rehabilitation and the behavioral health context. So my main duty today is one, to welcome you and to especially welcome you on behalf of the Department of Labor. My other duty is to introduce you to our facilitator for today. It is my distinct pleasure to introduce you to Dr. Lisa Mills. Dr. Lisa A. Mills is the author of the guide and facilitator of this webinar series. She is a consultant on disability employment policy with a range of areas of expertise, including state systems change focused on full employment and full inclusion, value-based purchasing and rate setting for employment and day services, interagency collaboration to advance employment first, and implementation of the Medicaid home and community-based settings rule and managed long-term services and supports for people with disabilities. Dr. Mills has 30 years of experience in the field of disabilities, having worked in both the United States and United Kingdom. She has worked in 22 states in the past 2 decades under various contracts with state and federal government agencies and provider associations. I've worked with Lisa for the past 5 years on various projects. She is a wealth of knowledge, and you guys are in for a real treat today, led by her. So without further ado, I'll pass it over to you, Lisa.
Thank you, Rose. Welcome, everybody. Appreciate you tuning in today. Next slide, we can get off of my picture. I'm very excited to share with you who's on the webinar with me today, because it's really their work and the outcomes they have to share that we want to highlight the most today. First, I'd like to introduce Dale Turrentine, who's the Community Program Development Manager for the Arkansas Rehabilitation Services Agency in Arkansas. Second, I'd like to introduce Anya Eliason. She's the Chief Financial Officer for Oakland Community Health Network in Oakland County, Michigan. Also with her today is Francisco Gamboa. Francisco is currently a rehabilitation consultant with the Michigan Rehabilitation Services, but previously was a contracts manager for employment services, also with Oakland Community Health Network. And last but not least, I have Stacy Smith, who is a behavioral health policy analyst from the North Carolina Medicaid Agency. And I have her colleague, Alice Farrar, who is the Chief of Employment Services and Program Development at the North Carolina Division of Vocational Rehabilitation. So you will hear more from them today as we move along with the presentation. Next slide. So I'm going to go through a few introductory slides before we get to talking about what Arkansas and Oakland County and North Carolina has done. If you've been on one of these webinars previously, some of this is going to be a recap. I apologize, but I find that hearing things more than once is helpful. I hope you agree. But I wanted to start with quickly stating the obvious in terms of the expectations that public programs do better around facilitating competitive integrated employment for people with disabilities. While in the past, it may have felt like this is a fad, it comes and goes, it just depends on whether there's a federal grant project or not. I think as we are moving forward more and more as seeing that this is not going away. The expectation of competitive integrated employment is really been consistent and strong for a long time, and I expect that it will continue. And we all know we have to and we want to do better. Next slide. So I still find, though, that too many people still hold the opinion that public programs just can't do better around competitive integrated employment for people with disabilities because there just isn't enough money. But I do think that there are some of us, although too few, that believe that we can do better if we can use the existing money we do have more wisely. So while there's no question that more money can often be a catalyst for better outcomes, although not always, there is always an opportunity, I think, within existing funding to find better ways to use that funding. Next slide. So we know that adequate payment rates for employment services are becoming a priority for federal funding partners. On the Medicaid side, there's more and more emphasis on states being expected to ensure that home and community-based service programs ensure rate sufficiency. And CMS has been very much clear with states that they are expected to review their rate setting methodologies for HCBS services at a minimum every 5 years to ensure that rates are adequate both to maintain an ample provider network, but also to ensure quality in services. And I think that second point is hugely important with regard to employment. We know that without quality services, oftentimes we will not get outcomes. On the vocational rehabilitation side, the RSA has continues to expect state vocational rehab agencies will have statewide fee structures that are based on an accurate understanding of their vendor costs. in terms of providing the services. Next slide. So as there have been more and more conversations in states about how much are we paying enough for employment services? We're seeing states and other purchasers, sometimes in the Medicaid world, that might be a managed care organization, it might be a local government, like in the case of Oakland County, who's with us today. We're seeing those funders not only want to assess how much are they paying for employment services, but how are they making those payments? In other words, what's the specific methodology they're using? And as that has been the conversation, we're seeing much more discussion move towards the idea of paying for outcomes and quality rather than solely reimbursing for the services delivered. So we're seeing more of what we generally refer to as value-based purchasing. There have been many new models and approaches. You're going to hear about some of them today. In the last 10 years, as we've increasingly thought about the importance of funding structure for advancing competitive integrated employment, there wasn't really one guide you could go to see a whole range of examples across different systems and states and across different populations. So I'm very fortunate that ODEP gave me the chance to put a guide together. A lot of the examples I actually had the privilege of being directly involved with, but there are some in here I just did the research and wanted to make sure they were included. So that's what's in the guide, a lot more than we can cover today, but hopefully the examples we dig into today will be helpful to you. Next slide. So in the human service world, it's probably an uncomfortable truth, but an important truth that money does drive behavior. It doesn't seem to matter whether money is scarce or plentiful. It tends to drive behavior in certain ways. And I do believe, though, money is more scarce, it drives behavior more, but I would say that across the board, money still does drive behavior. And what I've learned over the years in looking at a lot of rate and reimbursement structures that are out there is that there are financial incentives and disincentives in every structure. You can't have a structure that has no type of incentive or disincentive. So they always are built in. The key question then is whether those financial incentives and disincentives really align with what are the opportunities and outcomes that you really want to get from the services you are purchasing. And sometimes it's about looking at how to realign the financial incentives that are there to better support outcomes. Next slide. So another thing that I've realized over the years in working on this is a big driver of behavior other than reimbursement rates and methodology is how hard it is to do something, and particularly if it's something different. We have to think about, I think, that sometimes we can pay more for something that we would like service providers to do. We could pay them more to do that than other things they do for us. But if what we want them to do is actually harder for them to do and it may cost more, and on top of that, if it's different from what they are comfortable and experienced doing, we have to make sure that the amount we pay lines up with the incentives they need to move in a new direction. Because you could end up adjusting rates only slightly, concluding that, well, this rate's higher than this other one, so this must be an incentive. Well, and in fact, that's not always the case. We have to kind of dig in underneath and look at cost to provide the service, difficulty to provide the service, and how much experience people have. Next slide. So I have, in the guide, I kind of lay out some lessons learned. And for me, there's 4 key starting points for success in trying to develop good rate and reimbursement models that will lead to better outcomes. First is We've got to be able to recognize when the existing payment structures and incentives we have in place don't actually contribute to the outcomes we desire. So they are creating incentives that aren't necessarily tied to the outcomes we want. In some cases, our payment structure might actually even undermine the better outcomes that we desire, or it works against those outcomes. The second thing is setting aside the belief that cheap is cost effective. Finding the cheapest short-term cost is not necessarily going to create the most cost effectiveness for a funder or a system. And that goes along with number 3 here, embracing the belief that penny wise may often be pound foolish. So sometimes we are looking only at the here and now, and what is the most, the cheapest way we can get services purchased right now. And we're failing to recognize that by doing it that way, we're actually spending more in the long run. And we may also not be helping people achieve the best outcomes. So the last thing is really super important, and I've touched on it already, is just rejecting the assumption that what our money can produce in terms of quality and outcomes for people served is purely determined by how much money we have and not how we use that money. So these are my kind of 4 starting points for success. Next slide. So the next thing I talk a lot about in the guide is what I've learned about stakeholder input and engagement. I have in the past encountered funders who say, we can't talk to providers about this. We can't bring them in until we know what we're able to do or what we want to do. I really recommend trying to find ways to build new reimbursement models together. That the input that stakeholders, particularly providers, individuals receiving services, bring to the thinking that we have around how to develop new approaches is critical. And rather than just asking them, you know, what should we change? Give us your input, or what do you think of proposed changes we are rolling out or we're thinking about rolling out? It's really about trying to find a way to build the structures together. And that seems to me, in my experience, to lead to the best outcomes. Providers are typically very committed if they get the opportunity to build those structures with funders, and they are committed to the extent they will collect and share data, participate in impact modeling or piloting, really invest in trying to find the right way forward. And you can see this little cartoon's one of my favorites, where the caveman offering them wheels, round wheels for their wagon, and they're saying, no thanks, we're too busy. Oftentimes I see that happen with a lot of good ideas that could make a difference. We just don't have time or make time to hear the input. Sometimes there's a really open-ended time frame where you can go at your own pace with stakeholders in terms of building new structures. Other times it may be a short window because you've got a budget cycle to address. So it all depends, but in any ways you can engage stakeholders in the actual process of development. I think in the end you get better outcomes. Next slide. So I also say, you know, don't reinvent the wheel, but also don't simply copy it. When you begin to look at possible ways to engage in different types of rate methodologies, different rate models, it's really important not to work in a vacuum, to reach out to find out about others' approaches. And I really stress the advantages of learning with your stakeholders, particularly with your provider community, bringing in folks who can share perspectives from elsewhere on the work, and everyone hearing that at the same time. But ultimately, copying from another place typically does not work either. So you'll have to build your own model. But hopefully it will be inspired and informed by what you've heard about other models and how they're working. I find we just keep moving our thinking forward because everybody who does this typically listens to the presentations on other models and then says, I like that, I like this about it, but I think we can build an even better model. And that's how we advance our thinking for the entire field. Next slide. The other thing that's so critically important here is balancing the advantages of a new structure. It's not unexpected that funders and providers would naturally want the reimbursement methodology and the rate structure to be the most advantageous to them. But it doesn't work when the funders want the most advantageous model for them, which is typically pay a little and get a lot. And then the providers would like the model most advantageous to them, which is do less and get paid more. And of course, that doesn't allow for any kind of model that's a win-win. So what I found is it's really important for both funders and providers to come together with a sense that we have to balance the advantages of both funders and providers. We have to find a way that neither of us are going to get everything we want, but we're both going to get enough value and benefit out of the model that we are willing to go forward with it and with real fidelity to those intended outcomes. Next slide. So we're going to talk today about supported employment. And one of the key reasons about 15 years ago, I kind of came to this conclusion with help from others who I was talking to in different parts of the country, that we really need to move to an outcome-based model of funding for supported employment for the very simple reason that's illustrated on this slide. Best practice supported employment typically means that the more capable an organization is, the less hours of service they need to deliver that service, the less time it takes them to find people good job matches, the less time it takes them to get them oriented and trained in their job so that the provider can step back. But with a fee-for-service model, any model that reimburses based on time, the more capable organizations, as a result of being more capable, actually end up getting less money from us. And that's a key problem that has undermined the growth of supported employment for a long time. We are finding in the fee-for-service system generally that providers who do exemplary work often earn no more than the providers who don't do exemplary work. And in some cases, like here in the case of supported employment, they may earn less. Next slide. So moving beyond a fee-for-service model with providers, moving them to a performance or outcome-based model involves supporting those providers to be successful. It isn't enough just to shift your model and let providers figure it out. I think the more that I've seen funders work with providers to develop their ability to succeed in a performance-based model, the more the funder has gotten what they wanted in terms of outcomes for individuals served, and the more the provider network thrives. We have to help providers figure out that the budgets are no longer based on maximizing volume of service delivered. They're now going to be based on performance measures and meeting milestones. And I see providers increasingly interested in making this shift because one of the things it does for them is it allows them to reduce the number of direct service workers that they need. And with the tremendous direct service shortage that just continues to plague our systems, if we can show providers how they can do well with less direct service workers getting paid for providing less service, but a more effective service, they really recognize that that's something that they need to move in the direction of getting to because of the workforce crisis. A lot of providers also want to do well by people. They want people to be as independent as possible, but they are torn if a fee-for-service structure doesn't really reward them for doing that. Next slide. So I'm going to talk through now the inspiring examples with the folks we have on the call today. I want to talk through the models they developed and have them answer a few questions that I am going to pose to them about that. Next slide. So I want to start with Oakland County Community Health Network in Oakland County, Michigan. They provide Medicaid-funded services, including long-term services and supports to, I think, over 27,000 individuals with developmental disabilities, mental health disabilities, and substance use needs. Back in 2015, I got the chance to start working with them, and they decided to move from purchasing individual placement and support, IPS supported employment, to move from paying for that based on fee for service to paying for that based on milestones. So I wanted to give you a sense of the model that they developed. They worked with their providers to develop this process and determined what the payment structure would look like. They have typical milestones you may have seen for IPS, but they've nuanced some of them to really get at key quality outcomes that they wanted to see occur. So there's a milestone for engagement, but what I want you to notice first is what's across the top in terms of how they tiered the milestone payments based on the provider's Fidelity score. So they didn't offer just a flat payment. They wanted to offer tiered payments to encourage providers to continually try to improve their Fidelity. And so you can see there's 3 different payments here. Milestone for engagement, milestone for vocational profile and job search plan. And then you see they added a bonus in for rapid job hire. They recognized that in some cases, providers would be able to do the profile and job search plan process in a way that the person ended up with a good job match available to them at that stage. And they wanted to make sure that the provider went forward with making that connection for the individual and was rewarded for that, because obviously the follow-along cost of separate job development didn't occur for Oakland County, and they were able to return a portion of that savings back in the form of a bonus. So you see that here. Next slide. The next milestone was job placement, paid after 14 days on the job, again, tiered based on Fidelity score. They also wanted to see people earning higher wages than the lower end of the spectrum, very near to minimum wage. So they put a bonus in place for job placements where the wage was $13 an hour or more. And so again, that was getting at what are the key quality measures we are looking at in addition to people achieving outcomes. Next slide. Next, we look at job retention. This was interesting. I remember working with the providers on their data and what they knew about at what point in terms of how long people have held a job do they get to a point where long-term retention is highly probable. And in working with the providers, they communicated that at roughly 120 days or 4 months, that the individuals who made it to that point typically were going to have long-term job retention. So Oakland set the job retention milestone to trigger at 120 days. And you can see they tiered this in a couple of ways. First, there's a higher payment based on Fidelity score, but then also higher payment based on how many hours a week the person is working, both to incentivize higher hour jobs, obviously, but also then to recognize the provider may be doing more and have to put in more time if a person was working substantially more hours a week. So they were able to incorporate that into the model. Next slide. Last milestone, job leave and reemployment within 90 days. This was, again, another thing that was identified as an area where they wanted to incentivize reemployment quickly if there was a reason why a person left a job, because that how quickly they got reemployed tied to whether they continued to be employed. So they put in place a milestone that somebody leaves a job, the provider works with them and they're reemployed within 90 days. There would be a payment made to the provider for that work of getting the person reemployed timely. They also, again, implemented the bonus if the wage rate for the new job was $13 an hour or higher. So I want to stop here to stop me talking, and I want to ask Francisco Gamboa to comment here, since he worked closely with the IPS providers in Oakland County, both before this model was put in place and then for a number of years after. I would like him to reflect on why he thought moving to this model might be advantageous for the IPS providers in Oakland County.
Sure, thank you, Dr. Mills. Oakland County has 3 contracted service providers, each with their own individual IPS program. And there had been considerable work and effort focused on Fidelity prior to any conversations about rate restructuring. Still, despite these efforts and this attention, IPS was simply one of many programs competing for limited resources. And so while the IPS programs were getting good outcomes, unfortunately, funding was still a challenge. So I was concerned that IPS was maybe not on fair footing with other programs, that there were other programs where it's kind of getting back to the quality versus quantity debate, where quantity and a reimbursement system that may have favored those. And so IPS maybe wasn't getting the fair attention or resources that it could have benefited from. So as evidence of this, Oakland County had spent significant time and resources messaging community inclusion and the benefits of competitive integrated employment. So we had started to see a lot of enthusiasm and excitement building for services like IPS. But as I mentioned, the staffing levels have remained flat despite this growing demand. So I think by being able to flip the script, the key advantage, one of them that I saw was being able to put IPS, like I said, on a more equal footing and really help program administrators see the value of IPS, seeing IPS in a different way, really allowing the program and its outcomes to shine, and that while it made sense to devote financial resources to it. So really looking at additional resources and maximizing current resources for efficiency's sake. The other area that Dr. Mills touched on is the tiered milestone reimbursement scale. That was really important because you certainly heard me mention Fidelity. And sometimes, unfortunately, an initiative can be something that's kind of the topic of the month, but Fidelity is so important. We wanted to make sure that that remained a focus for the foreseeable future. And so having it built into the reimbursement kind of ensured that it would live on indefinitely. So, and like I mentioned, maximizing resources, having the correct resources allocated would also prevent the potential of a wait list and being able to serve those interested in employment service in an efficient manner. Obviously, one of the core principles of IPS is rapid engagement, and we certainly wanted to make sure that we were in alignment with Fidelity.
Thanks, Francisco. One more question. As you implemented this model, how did it help IPS providers expand their capacity to provide IPS? Why would this model help in a way that the fee-for-service model would not?
Yeah, I think it really helped the administrators make more of a connection between outcomes and reimbursement, and that it was a win-win, that these were not competing or opposing ideas, that you could have good outcomes and good milestones and be rewarded for it. So it allowed the conversation to kind of shift and those resources to be allocated to the program, which was what we were hoping to have happen, because as I mentioned, there was some staffing concerns as far as lack of staffing, and then those efficiencies that we wanted to recognize. So it allowed exactly what we had hoped, which was more individuals to be served with IPS services without delay, and for those individuals to achieve more outcomes or more milestones. So we're very, very happy with those results.
Okay, thank you. And I'm just going to ask for them to move on the slide here so we can look at some of the outcomes that occurred. This first slide shows the number of people that met each of the milestones and the number of individual milestones that were met and paid really in the first year of the project, and then of the initiative, and then I'm going to show you what happened multiple years on. So you can see nearly 600 people meeting milestones and over 1,000 milestones met and paid by Oakland. If you go to the next slide, here you see the number of people meeting milestones. The first year is the one I just showed you on the previous slide with 596 people. But you can see what happened then in subsequent years in terms of what Francisco was talking about in terms of growth of capacity of the providers to really serve people. After this model was implemented, you can see the significant growth in the number of people being served each year. Even FY20, even with COVID hitting, you see some reduction, but certainly not as much as many would have thought. And I'll just comment, the FY21 numbers are just Q1 and Q2. So if they stay on track with that, they're looking at 900 people receiving services in FY21. So certainly in terms of them wanting to see more people being able to access IPS, they're seeing that. And if we go on to the next slide, you're looking at the growth in the number of milestones being met each year. Of course, this correlates to more people being served, but you can see the growth in milestones being met annually with only a slight drop around the COVID time. And this year looking like even with COVID, they're still going to hit pretty significant numbers. A total of 4,600 separate individual milestones paid across this period of time. And so now I'd like to turn and put a question to Anya Eliason, who's the Chief Financial Officer for Oakland Community Health Network. And just to give you an idea, this county system contracts for roughly $319 million in services every year that Anya manages and is responsible for all that purchasing. And I want to ask you, Anya, in looking at this, I mean, you were directly involved in helping develop this. You sat at the table with the providers and worked with them on this. What are the main advantages that you see of paying for IPS through milestones rather than fee for service from your perspective as a CFO?
So from my perspective, we gained guaranteed milestones. I mean, the way we were paying before just meant that a service happened. It didn't necessarily mean that people actually got jobs and kept jobs. And so by moving it to the actual outcome we wanted to see, we were able to ensure that that's what was actually going on. And outside of this, having, we all know the statistics on the impact having a job has on a person's life. So it impacts things far outside of just having a job. So I think it's a way for us to invest in the long-term efficiency of our system and the long-term social determinants of health for the people we're serving.
And just to follow up on that question, since you touched on the broader impact of people having a job, how do you see that affecting the cost effectiveness of investing in supported employment for people with behavioral health needs?
So what we see, and of course, COVID has paused a lot of our data analysis just for that third year there, or fourth year. But we see people with better community connections. We see people with a social support network. Being able to generate your own income helps with, the ability to afford, things in your life and keep yourself in a place in your life where you feel independent and in control of your future. So there's a lot of benefits that are less quantifiable. So as a finance person, sometimes it takes a little bit to get past, the hard numbers, but we definitely do see that in these latter years that the things that were harder to quantify up front are definitely starting to show, and we're able to see, you know, the value it has on people's lives long term.
Thank you. Thanks to both of you for those comments. I'm going to move on now to North Carolina. Next slide. So I want to talk about North Carolina's process, the pathway they took to getting to milestone-based reimbursement for IPS supported employment. Early on, the Vocational Rehabilitation Agency and the Behavioral Health Agency really recognized they wanted to move to value-based purchasing because they really they saw that reimbursement policy was likely to play a critical role in whether or not they could grow and develop a strong, competent statewide IPS provider network. So there were lots of other things they could do to get that strong network, but they recognized reimbursement policy had to be one of those things. So they began on a path, rather than flipping a switch, they began to take incremental steps to get there. And I think it's pretty amazing in terms of how these steps fit together and got them to a fully outcome-based model. So they began in phase one with the Behavioral Health Agency. They introduced just a simple set of tiered fee-for-service rates for IPS that would begin to reward IPS teams for achieving fidelity. Next slide. So as you can see here, what they did is they changed the fee-for-service rates so that there were two different rates. One for a IPS team that achieved fidelity and was providing these services, and for those who had not yet met fidelity, they were paid a lower rate. They did give providers, new IPS teams, a certain amount of time to achieve fidelity before the lower rate kicked in order to not put them at a disadvantage. This worked. What happened was IPS teams began to try to meet fidelity. What they discovered, though, is, of course, they would get to fair fidelity, the lowest level of fidelity, and because that was considered met fidelity, they would stop there. They didn't necessarily have an incentive to invest the additional resources and energy in trying to move from fair to fidelity to good and to exemplary. So this wasn't a failure. This began the process of moving them in the right direction. And so the state recognized that it was time to make another adjustment. So next slide. What they then did is create the 4 different rates based on the level of fidelity. And so this created that incentive that had previously been missing for a provider who'd achieved fair fidelity to actually aspire to good or exemplary fidelity. So they did establish the standard unit rate as applying to good fidelity. So they immediately kind of set the bar a little bit higher than fair. And then what they did was adjust the rates accordingly around that. For exemplary fidelity, which is where they want providers to ultimately go, they set that unit rate 25% higher than the standard rate. For fair fidelity, they set it 13% lower. So there was a reason to, if you were at fair, to get to good at least. And then obviously for an IPS team who hadn't pursued any level of fidelity, they set that unit rate 35% lower than standard, still giving them a window of time where they could earn, if they were new, earn that standard unit rate and get themselves up to that level of fidelity to maintain it before they would otherwise see a decrease. And this worked as well. What they saw happen next was IPS teams achieved and sought higher fidelity scores. So they were figuring out what it would take. And I just want to pose a question now to Stacy Smith from the Behavioral Health Agency in North Carolina, because she has championed this process, multi-year and multi-phase, this process. And Stacy, I just want to ask you, what was really important is you didn't assume that the first payment structure you put in place to encourage Fidelity was going to be the end. It was going to be do everything you wanted. You knew, watching what was happening, that you would have to adjust again if you wanted to continue to promote Fidelity. And so you did this. I think a lot of people might be intimidated about the idea of how hard it is to get changes to payment models and rates into practice in state systems. And here you're showing that you not only did it once, but you did it twice. What was it that made it possible? How did you go about convincing leadership to make one change in the model and then make yet another change in the model fairly soon after?
Well, thanks, Dr. Mills. First, I have to say, when I was at DMH, I had an awesome team that was just super trained in IPS and very plugged into what was going on in the field, and that helped. And we also had a great partnership with our Technical Assistance Center as well that was really supporting teams and improving their fidelity and trying to get those higher rates. I think we realized that we needed to add another layer after the tiering of the rates when we tried to start to track the actual outcomes and track service delivery through the units. We realized we didn't have reliable person-level outcome data, and we didn't know how the service was helping people move through either employment or education. Our providers were supposed to be completing something called NC TOPS, and when we coordinated with our QI department, we found it wasn't being reliably done, so we didn't really have a good set of outcome data. And then we tried to pull outcome data through claims, which is kind of one of the best ways to pull outcome data because we were paying fee for service on our end. All we could tell was the dose and the length of treatment that people got, but we couldn't tell how long it took for them to get a job. Did they advance in that job? How long they kept the job? Did they go back to school? We didn't have access to any of that. So I wound up talking to Alice, my counterpart at VR at the time, because I knew that when VR paid for the service, they were not doing it through fee for service. They were doing it through Milestones. And the way IPS is funded in North Carolina across the state is it's a blend of VR funds when the person is eligible, and then state or Medicaid funds, depending on if the individual is insured or uninsured. And our state and Medicaid money was fee for service, and I knew Alice's money, the VR money, was paid through Milestones. And so I started talking with her about what she could see when she pulled up the Milestones, and she was able to talk about how she could see where people were moving through the system and about how long it took and when cases were closed. So we really started to dig into that back in like 2017. So I understood her system and she understood my system, and we started to try and find ways to get those systems to merge. The focus on the state and Medicaid fund kind of sequencing into what they already had. So after we kind of understood each other's language, I took it back to the DMH leadership at the time and kind of pitched a really rough proposal about how we could sequence the funding so that we could get teams using VR services funding better, and also to be really more mindful of how the state and Medicaid funds were being used. The other thing that we did was we, as a team at DMH, kind of looked at where our pain points were with IPS, and we kind of identified the biggest pain point being IPS teams were really not using VR funding, which created an extra burden on state and Medicaid funds because teams were not billing VR for the functions that VR would pay for. And we had a lot of MCOs running out of state funds for IPS services at the time. Another pain point was we didn't really have good, reliable outcome data on how the service was or wasn't helping individuals find employment or go back to school. And we did get feedback from the teams that the current payment system and authorization system was pretty burdensome administratively. So we kind of looked at how we could add in milestones that not only wrapped around the existing VR milestones, but also aligned with the model. And after we felt we had a good roughed out structure, we pitched it to leadership at DMH and also Medicaid. They had a chance to provide us input. We kind of tweaked a couple things, and then we asked about moving forward, and they gave us the opportunity to reach out to our LME MCO partners and try to identify one to partner with to implement this. So it really was a process of looking at where our pain points were, or where we were missing data, and how we could change payment structures to kind of lessen those pain points.
Okay, thanks. I'm going to move us on to show that model in more detail. Next slide. So the actual phase 3 that Stacy just alluded to was a movement from those 2 prior models, which had really, I think both of those models had really encouraged IPS teams to get to the highest level of fidelity they could get to. And that's the perfect time then to introduce milestone or outcome-based payment structures, because providers are likely to do well. So at that point, as Stacy mentioned, VR and behavioral health worked closely to develop a fully aligned payment structure for IPS. And I'm going to show it to you, but I would like first to I would like to ask Alice Farrar, who is the Chief of Employment Services and Program Development at North Carolina VR, to just talk about what were the advantages of working with the behavioral health system to actually commit to a fully aligned braided funding model, rather than, in a lot of states we see systems want to maintain their own models. They don't want to kind of share the process. They just want to have, well, we'll pay for it this way and you pay for it that way, and we'll just decide where consumers get sent. What made you think it was really worth it to have a blended model with behavioral health?
So thank you for the question, Dr. Mills. So for a very, very long time, the Vocational Rehabilitation Agency has been able to place people with severe and persistent mental illness without too much difficulty. And where we struggle is those individuals that we've placed, helping them maintain that employment. And what we've seen with IPS is it really provides the funding for the wraparound supports that this particular population needs to be successful in maintaining long-term employment. So IPS for us is really another tool that we can use to help our consumers reach competitive integrated employment. And I think that what we realized is that we're stronger when we're not working in silos, and when the IPS team can tap into the employment expertise that the VR agency has, then we provide a stronger service to our consumer. And Stacey's exactly right. The state funds started to dwindle, and we have money that we could support IPS. And so it's twofold. One, it's a tool in our tool belt that we want to keep, and we see our partnership as a way to sustain the model for the long term.
Great, thank you. So now I am going to show the model and then circle back to you all with one last question. Next slide. So this is the braided funding model that North Carolina is currently using. You can see engagement is funded on the behavioral health side. That very long acronym means the Department of Mental Health, Developmental Disability, and Substance Abuse Services. That is the behavioral health agency. So they pay for a milestone payment for the outcome of engagement. They also, in the agreed braided model, they pay for intake and career profile. And you can see they clearly identify the outcome, what triggers the milestone payment. And they also set up appropriate limits on how many times the service can be authorized. I think it's important to note, engagement can be authorized a maximum of 3 times. And we know that sometimes when we circle with people around employment, the first time we engage them isn't necessarily that time where they will then grab on and pursue. So if we can come back to them, have a much better chance that they do end up in employment. Next slide. You see here, the VR agency now becomes the primary and first payer for job development and retention. They pay that outcome payment of $3,200 after the person has maintained employment for 3 days. But you also see here that that the behavioral health agency recognized that sometimes a person needs this service more than once. And to maintain them in competitive integrated employment, job development and retention has to be authorized more than once. So you can see here that the behavioral health agency said we will pay if this is needed again, we will pay for that. It's a substantially lower rate because they're working with somebody they already know, but they are allowing that to be authorized up to a maximum of 5 times, and that is obviously based on their learning and data around IPS and what has worked well and been effective in North Carolina. You can see next, successful closure, that again, North Carolina VR is the primary payer. They will pay the closure payment when a person completes 90 days after they enter the point of stabilization. But you again see if in fact someone needs a job development done again, that behavioral health will fund the milestone at a lower level for successful closure. And they, of course, the limit is the same as job development. So a possibility that up to 5 times, obviously that's the extreme, but up to 5 times they would have this available to them. Next slide. So then we see the shift back to behavioral health as the primary payer. They have, and I think Alice alluded to this, the importance of sustaining people in employment beyond the VR closure, case closure. Behavioral health decided that they wanted to pay for successful sustained closure, because obviously we know if people lose employment, the process of reemploying and starting over again oftentimes costs a lot more than it does to make strategic payments for sustaining employment. So behavioral health will pay a milestone payment when a person has achieved 4 months post the successful closure paid for by North Carolina VR. So that would be, I think, if I'm adding right, 7 months post stabilization. And then there is a vocational advancement component and a milestone available for that. I think this is hugely important in any supported employment model, that we are always looking at making sure people have opportunities to advance in their career and in their employment situation. So in this case, behavioral health is paying a milestone where an individual receives a promotion or they successfully complete an education program that improves their qualifications. So then they would be well placed to receive a promotion at a future point. Before I go on, I would just want to throw out to Stacy and Alice, either of you or both of you, as you have piloted this milestone model now, can you talk about the benefits you've seen for your agencies and the people served? Anything you haven't covered yet in your comments?
Sure. So I think the first thing that we've seen is this Milestone Pilot has actually brought not just Division of Mental Health, Division of Health Benefits, which is Medicaid, and DVR closer together. We have a really strong, positive working relationship with the LME MCO that we're piloting this in. We regularly touch base on, is this model working? What can we do to make it work better? And how does it need to be adapted to better meet the needs of not just the individuals receiving services, but also the providers and the LME MCO that's managing it. And that was really important when COVID hit. our pilot started 3 months before COVID kind of shut everything down. So that made it really, unfortunately, ill-timed, but it was nothing, it was no intentional planning on our part. So I think that close, positive, open communication, that great relationship was one thing that came out of this. On the state side, with the MCO, and we have 7 MCOs, this is being piloted in one. The MCO that's piloting it, we noticed a significant decrease in the dependence on state funds by providers. And that's really critical for long-term sustainability of this service. Our state funds, probably like a lot of other states, get routinely cut every year. And there's a lot of competing interests for those state funds. So whenever a service is heavily dependent on state funds, there's always concerns about sustainability. And we found that the MCO where this was at, they, I think we pulled data back in March. Our fiscal year runs July to June. And in March, I think they were at about 10 to 15% utilization for their full allocation. The next lowest was at 50%. And in March, we actually had 2 LME MCOs that had fully spent all of their state funds, which means that they either have to pull state funds from somewhere else, or if an uninsured individual wants that service, they're not going to have funds to help them. In the MCO that we saw this being piloted in, we saw an increase in individuals that qualify for our settlement agreement with the U.S. Department of Justice actually getting this service and receiving supports from it, which was helpful. Saw a significant increase, not only the number of shared cases with VR, but shared cases that were entered into BEAM, which is the process that they use to bill VR for the milestones that VR pays for. Alice, anything to add?
No, well, Stacy, you hit the nail on the head with so many positives that we've seen in this pilot project. I think for on the VR side, the increased partnership and collaboration has really driven some improved service delivery and employment outcomes, and our not siloed approach to employment services and being able to share employment expertise has resulted in some really fantastic employment outcomes for people in that catchment area. And it's, you know, with our VR counselors involved in the delivery of IPS, you got another person that's delivering the very same message with a slightly different perspective. And you never know when something is going to stick with one of our consumers. So it's nice to have the same message shared in so many different ways.
Thank you both, and glad to hear that the pilot is going that well. So hopefully it'll be scalable to more people and more MCOs as you go along. I'm going to move now to our last state guest. Next slide, and I'm going to talk about Arkansas's rehabilitation system and their implementation of what they call employment first career pathways. And I am pleased to have Dale Turrentine here, which back when they were developing this, I was working in the state of Arkansas, and it was great for her. She has some data that I'm going to share to show you the impact here. But I think this example teaches me that it does not matter where you are as a state. There are always opportunities. And no matter where you start, if you develop a model that works, it will move your system forward. And then there will be the possibility to take that progress and leverage it to move even further forward. So back before this employment first career pathway structure was put in place, Arkansas contracted with community rehabilitation providers in what I would describe as kind of a bulk contract. They contracted for services for people they referred. They did not contract for outcomes. What they did was they transitioned to this outcome-based payment structure At the same time, also expecting that the services to be delivered would be those that were evidence-based and that actually were known to lead to competitive integrated employment outcomes. So prior to that, they were contracting on a fee-for-service basis with CRPs, sending them referrals, and those CRPs were providing most of their services in-house. And so this moved to benchmark payments for evidence-based services that really had to be delivered in the community. Because what I mean by evidence-based is really that we know when people receive employment services in the community, that's actually contributes to their ability to work then in competitive integrated employment. So you can see they had discovery and a profile using the discovery process from customized employment. And they worked with data they had around the amount of hours it would take, the cost of the person or staff person providing it. They set an outcome payment for that. I think Dale also consulted some other states to see what they were paying. They then focused on employment path services. And in the guide, I talk about the original employment path services that developed in Oregon. But Arkansas figured out this would also be something they wanted to have as a component, so people would not be spending time on preparing for employment in a facility-based setting, but would be doing that in the community. And they created a payment for a certain number of hours to do that. They created a payment for job development and placement, and then for closure and retention after 90 days. This was focused, and I believe still is, on people with a goal and achieving an outcome of at least 20 hours a week. And if they needed individual job coaching, that was available at a separate hourly rate in their model. So I want to go on to the next slide, please, and show you the the early outcomes here for Arkansas. So prior to the change, when they were contracting for services that were largely in-house provided by community rehab providers, they referred 257 individuals and got only 9 closures. So when you look at that closure success rate, of course, that's a little less than 4%. They had paid for services for people, those 257 people, totaling $1.2 million. But when you took that and said, so how much did we pay per successful closure? You can see it was over $133,000. And I think Dale was smart enough to start to talk to her leadership about it's time to focus on outcomes and cost effectiveness in relation to outcomes. Once they put the employment first pathways models into place in the first 4 years, and this includes the COVID period, they referred 432 people. They got 69 closures initially, so they are at 16%. And I know Dale would say, and she probably will say, something akin to what Barack Obama says at the bottom of this slide, that we have to acknowledge where we've come from, the progress that we have made, still understand we have a long way to go. Things are better, but still not good enough. And I'll ask her a little bit about what their plans are to improve that closure rate even more. But what you can see is, by using that outcome-based funding model, they got 69 closures and spent $690,000, almost half, a little more than half of what they had spent previously. And the average cost per successful closure went from $133,000 to $9,990, much more in the realm of what we, see out of VR agencies nationally. So Dale, I'd like to ask you now, this slide really shows what happens when you evaluate the cost per successful outcome. If we look at prior to the change that you served 257 people for $1.2 million, that works out to an average of about $4,700 a person. Does not sound like a lot. except when you take account of how many successful closures you actually had. It is a huge difference, obviously, here in what you're paying for outcomes. Was that a big impetus for Arkansas VR doing this? And were there any other driving factors that affected it?
Well, of course, it was a big change for the state of Arkansas. We have a lot of our vendors that currently hold sub-minimum wage certificates, and these individuals were going in there for assessment, work adjustment, and then obviously they needed more work adjustment to the end, and maybe they got a job and maybe they didn't. And so we kind of just decided, due to return on investment, that we needed to shut the door on that. And, thanks to, and I think that our trainer is on this call today, but thanks to Griffin and Hammis, that's who we contracted with. And we thought we were going with customized employment before customized employment came a hot topic. And so we started focusing on having our providers focus on the clients, which we call preference, interest, needs, skills, and support, which is PINS in our world. So we keep reflecting on PINS, and we keep reflecting on trying not to get jobs in food, factory, filth, and there's another F. Can't remember what the other one is. But with that, we, our providers did not want to move to this, of course, because we had a couple of providers that ARS was the only funding that they were getting in their facility. One of them has a lot of Walmart contracts, and they were just sure they were not getting any waiver funding, and they were just sure that moving to this outcome base was going to, close their program down. And in fact, at the time, they were thinking about adding another 10,000 square feet to their buildings. And I just kind of looked at the director at that time and said, I wouldn't go there if I was you. So not only did we have to build capacity with providers, but we had to build capacity with our VR counselors, because it was real easy for them to just kind of write up a little VR authorization and send the client over there and just, not have to worry about whether they're going to have to find them a job or not for at least, several months. And so, with these lovely services that you spoke of, once again, we did have a 3-year contract with Griffin Hammis. And Corey Smith, if you're on here, I just have to thank you once again, because it's kicked us off. Obviously, we were a little slow on the uptake, and we're still working on it. There's still a lot of in-state training that needs to go on. So we will just continue to stay in the change. The driving factors with this, obviously, we had already made some changes, and then right before that, the Rehab Act came in with Workforce Innovation and Opportunity Act of 2014, which had the whole section on limiting sub-minimum wage. And so we took advantage of that. We were lucky enough in the state to get some technical assistance through Econ Sys that had gotten a contract from the Department of Labor. Thank you, Rose. And we, in the state from 2015 to currently, have worked with the other state agencies that serve people with disabilities to change the trajectory on employment for individuals with significant disabilities in Arkansas.
Thank you, Dale. And are there specific plans you have around tracking that 16% and trying to increase that in terms of referrals or focus with providers? What are your plans for moving that forward?
Sure. I don't know if all the other states experienced this, but I'm sure they did. The VR folks on here would understand when providers say, well, we're not getting enough referrals to sustain ourselves. And so we've been working with the leadership within our own agency about the need for referrals for these competitive integrated employment opportunities outside, of what we typically are used to doing. And we have created in our Arkansas WIOA, Workforce Innovation and Opportunity Act state plan, that we would create a statewide or regional committees on employment. And so that's in our plan of work to do that. We are also developing partnerships with, we have in 2019, our Medicaid funding went to managed care organizations, which they choose to call provider-led Arkansas shared savings entities here. And the focus has been on safety and welfare and not employment. So we have touched bases with them. We were working on individual placement support or support employment options for people with behavioral health before COVID hit. And we're just trying to get baby steps in with behavioral health. But the other thing that we do is we're going to work with the Arkansas APSE, and Disability Rights actually put out a paper on shelter workshops in 2018. We're going to be working with them to expand employment. And, you know, one of our biggest issues, especially in rural Arkansas, is transportation. How do you get to work? And the funding of extended services for those that are closed that are not on some other kind of Medicaid funding waiver. So that's our plans going forward. Our folks, as I was going to speak about a minute ago, our providers shut down for several months, and then they are the first people that got laid off were their employment staff, or they got assigned to be direct service providers. And so we have not seen the employment staff reinstated. They're still on limited participation at the developmental disability centers, but we have a lot of nonprofit or independent vendors who are moving forward with us on our different employment services that are not particularly connected to Medicaid waiver funding.
Okay, thanks, Dale. And I think there are two other F's, flowers and folding.
Yes. Flowers was when I was trying to think of. Yes,
yeah.
ma'am.
All right. So thank you for sharing that, for sharing your perspective on how this has rolled out and how it's driven change. Next slide. So I just want to tell you just quickly before we go to Q&A, a few more things that are in the guide in case you're interested. That I wrote a pretty extensive section on models for paying employers to provide on-the-job training and ongoing supports. And I used examples from the Medicaid system, where we've seen it in the state, my state where I live right now, Wisconsin, in Tennessee, and an old model that really inspired a lot of the thinking today from Oklahoma. Also talked about the VR on-the-job training and how the workforce system can pay for on-the-job training. I think it's really an important piece with the direct service workforce shortage that we are encountering right now, and our desire to normalize people's supports and their employment experience as much as possible. I think these models hold a lot of promise, and it's great to see that across 3 funding structures, we have found ways to support it. It is much more natural. The employer takes much more of an interest in that employee's success. And it works with businesses who would otherwise not want an external agency job coach or job trainer in their business, or frankly, where the business is so small, they don't even have room for someone like that. So I think there are multiple advantages, but the direct service workforce shortage is certainly one key thing that where we need as many strategies in the toolbox as we can find. So this is in the guide. Next slide. I also have a section on really what I think are really strong braided funding agreements. So MOUs, or memorandums of understanding, that do more than simply say we'll play nice together and we'll share data and we'll meet, but that actually lay out how they will share the responsibility for funding services in a model, in a braided funding model, similar to what you saw with North Carolina, and really spell out the commitments that they're making. I want to highlight Iowa there at the top because that model, I learned an awful lot working with Iowa. That model is very, very strong and covers both individuals with behavioral health needs and people with intellectual and developmental disabilities, interfacing with VR and Medicaid supports. I also want to highlight Tennessee because that was one of the first MOUs that really spelled out division of payment responsibility between the Medicaid agency and vocational rehabilitation. And then also there's an example from Oregon. Next slide. I also feature a few dedicated funding streams, which is where states have set up specific funding streams solely to support competitive integrated employment. You know, when states have limited funding, if they are funding a broad array of supports, they need more money and can serve less people with the same amount of money. If they target programs to supporting competitive integrated employment specifically, they typically can do that with less money per person and therefore can serve more people. So 2 examples are in here if you haven't heard about them already. Delaware has a Medicaid 1915I, it's called State Plan Amendment, called Pathways to Employment, that is specifically for younger people with a variety of disabilities, and all of the services available are designed to support competitive integrated employment. And then Georgia has something called an Employment Express, competitive integrated employment funding track that they put together to ensure where people would otherwise be on a waiting list for long-term supports to maintain competitive integrated employment, that they have created a special funding track for them so they can go ahead with VR services and get into competitive integrated employment and get the long-term supports they need. Next slide. So final closing thought. I think funding always creates potential, but funding does not guarantee outcomes. We have to work really hard in terms of how we use funding. And I've seen examples where less funding that's used more effectively through more effective funding models can produce better competitive integrated employment outcomes than when we see more funding used through less effective models. So I think funding only creates potential. You can do really good things with a little bit of funding that if you're thinking about the best strategy for that funding. Next slide. So that's my contact information on the left. On the right, one of my best friends. This is one of my favorite quotes. Yoda has said, "If no mistake have you made, yet losing you are, a different game you should play." And I know as we try to improve competitive integrated employment outcomes, it often can feel like, what are we missing? What are we doing? We're not making as much progress as we want. And I really think that looking at reimbursement methodology and outcome performance-based rates has a role to play in success. So I'll hand it back to the Lead Center folks to facilitate some Q&A.
Thank you so much, Lisa. That was just such an informative presentation and so much to think about. And also thanks to Dale, Anya, Francisco, Stacy, and Alice. It really was inspiring to hear what you've been doing in your states. We have a lot of questions that came through, and I'm going to try and combine some of them for efficiency's sake. There were a lot of questions about the individual placement and support model and how that works and what it takes to get to a Fidelity score and who contributes it and what it measures. So I'm wondering, I know Francisco responded in writing to one of the questions. Francisco, maybe if you wouldn't mind starting to talk a little about IPS and what Fidelity measures within the IPS model.
Sure, thank you. I put the website to ipsworks.org in the Q&A. That way individuals could access that link. But IPS is individual placement and support. It can be also referred to as the evidence-based model of supported employment. So it's a specific model that has been proven to generate higher outcomes. It's a model right now that's used in research. It's been used for different populations, but the evidence-based models for individuals with serious mental illness. And it uses a Fidelity scale to basically measure the programs and how close they are to achieving or following the 8 core principles of IPS. So some of those measures include rapid engagement, zero exclusion criteria, benefits counseling, time unlimited supports, collaboration with mental health treatment team, of course, competitive integrated employment. And so this model has been kind of tried and true. It's been tested. And so it's got the evidence to support that if you follow the model with integrity and follow the 8 core principles, it should generate and result in improved outcomes. So it's a widely adopted model. It's in, I think I've seen it quoted 22 to 25 states. It's international, it's in other countries. So it's a very well-known model. And so I would recommend those that are interested in more information, including looking at the Fidelity scale that has been mentioned, to see again how programs measure up, to visit the IPS Works website and kind of get familiar with it. So I can't say enough good things about the model. So we're very fortunate in Michigan. I think across the state we have 24 IPS sites, and in Oakland County, as far as what I was talking about, we have 3 IPS sites.
Oh, no, thank you for that very thorough answer. And there also were a number of questions about whether or not there is data on the rapid placement model. And I think the site that Francisco gave to go to ipsworks.org will provide you with that kind of research to see that. There was a question for North Carolina about how you support providers to understand the outcome/tiered fee for service-based system and how to improve their fidelity scores so that they can, over time, reach a higher rate of reimbursement. Stacy, were you going to speak?
Sure. So the first thing that we did was when the LME MCO stepped forward to be the pilot site, was we facilitated a joint meeting with them taking the lead and bringing in all their providers that were in their network for IPS. And it was actually, we had feedback on the model after that meeting. The providers worked with the LME MCO, and they came back with a list of changes that they would like made to the model. So not only did we do that kind of intensive outreach and education on it, we also took their feedback, and as we were able, we made some adjustments to make sure it was workable for them. With the training and the technical assistance, because we are under a settlement agreement with the Department of Justice, we have funding set aside for sustaining a training and technical assistance center, and it focuses on IPS, and it also focuses on ACT, Assertive Community Treatment. And we're currently able to support 6 IPS trainers located across the state, and they link up to the teams in their area. Majority, if not all of the training that they offer is free of cost to the providers. And not only are there regional trainings, but the IPS trainers are able to provide one-to-one agency-specific technical assistance. We also do the fidelity evaluations like Francisco was talking about, and the way that, excuse me, the way that the trainers complete those evaluations, there's a very detailed agency-specific QI plan based on what they find when they complete that fidelity review that kind of goes step by step through, you know, if you want to make some changes and improve your practice, these are the top 3 to 5 things that we would recommend looking at.
No, that's great. No, thank you. Thank you so much. There are a number of questions about how things are paid for and whose responsibility it is to pay for things like job coaching or classes that someone might want to take. And I think Lisa's slides toward the end that talked about other things that are in the guide, it sounds like that the guide will provide you with some of that information as you look at the formal agreements that are made between different agencies. Lisa, do you want to say any more about that?
Right, yeah, I don't think there's this clear-cut answer to that question, you know, who is it, because there is an overlap in terms of what funding systems can do. I think the best thing is to really sit down and commit to those graded funding agreements and to what is fair and equitable in terms of cost sharing, that makes sense to know what if I'm from one system, what are the things that only I can do? Or the other system, what are the things only that system can do? Clearly, those are the things that are, we can put them in one bucket or another. But what really matters is when we get into the idea that, well, multiple systems could do this for someone. How are we going to create a fair and equitable arrangement for how we're going to cost share rather than cost shift? And I think that's really critical.
No, thanks. That's helpful. And it sounds like there'll be great information in the guide. We're not going to be able to get to all of the individual questions. If you could go to the next slide. We wanted to let people know that there's an upcoming webinar next Wednesday, May 26th. It's on practices in workforce employment network operation. There's a new technical guide and desk aid that will be released and covered in that webinar. The guide is the result of a joint effort from the Office of Disability Employment Policy and the Employment and Training Administration, both at Labor and the Social Security Administration. You can register for it at workforcegps.org. And if you're not already signed up to get information from Workforce GPS, we encourage you to do that. There's a disability employment community there, and that's where you'll find more information about this webinar, but we encourage you to participate in that. Next slide, please. We also encourage you to visit the leadcenter.org website, where you'll find a lot of information on customized employment, on WIOA from a disability perspective, on topics like this, and you'll find archived webinars and slide decks and things like that. We also hope that you'll sign up to be on our mailing list and to get notifications of additional webinars and briefs and things like that we're going to that we'll be releasing over time and that may be archived there. I once again want to thank Lisa Mills, thank Rose Warner for coordinating the entire webinar series, and special thanks to our guests from the States, Dale, Anya, Francisco, Stacy, and Alice. Thank you all for participating in the webinar, and stay well.